And welcome officially great. Good morning. Hello, Marcia and Michelle. Welcome into Test Your Skills. This is going to be a very fun, kind of short presentation, just designed to get you a little bit of a test in your skills so you can see where you are, engage your own knowledge. Because we do a lot of teaching in this group. And yes, of course, Michelle. So we do a lot of teaching in this group, and we in the 3-day EKG challenge, all the bonus lectures that we do, and we want to see what has stuck and maybe what you need more help with. So we're super excited about this lecture. When I was dreaming it up, um, I thought about it being kind of a race car scenario where we start our engines and we go really fast through the EKGs. So what we're going to do is we're going to have you first look at the EKG when we put them up. And what I want you to do is I want you just to gut check yourself. I want you to look at the EKG and think to yourself, okay, how alarmed am I? How worried am I? What do I think's going on? And what would I do if I had to make a decision right now? And then after that, we'll kind of pick it apart. But I want you guys to just to yourself, or you can type in the chat, however you want to do it, but really make a commitment because this is the way you learn. And we love doing this kind of learning. So welcome in everybody who's just joining us. Hello, hello. We have Rebecca, we have Rita, Teresa, Melanie, nice to see you. Kimberly, hello. And Marcia, hello. All right, so let's kick this off. So in case I haven't met you before, this is me. I am a now only cardiology PA working inpatient. Previously, I was working both ER and outpatient cardiology for 16, I think we're on 17 years now, but who's counting? And in case I haven't, again, if this is my first time meeting you, I did my training at UC Davis in the FNP PA program back and graduated in, I don't know, like 2006, I think. And prior to that, I was a paramedic for 13 years. So I have to admit, though, yes, I write for journals and yes, I lecture all over the country, but I have to admit that I have not always been comfortable with EKGs. And it was that discomfort that caused me to find a way to jump over that hurdle to get comfortable. So what I did was I started doing some self-teaching. I started reading books, but books didn't really help. And it wasn't until I got a mentor, and I've told this story, so I apologize if you've heard this before, but I got a mentor at the emergency room. He was a nurse, and I only luckily got to have him as my mentor because my roommate was good friends with him, and he felt bad for me. I don't even remember what I paid him. I was eating ramen. I was a student, right? So I didn't have a lot of money, but luckily he took pity on me, and that for me was the turning point where I was like, okay, now I can make the light bulbs go off because I don't feel like you can really learn everything you need to know from a book or really everything you need to know from a video. You kind of need it from multiple different sources because this is multi-layered stuff and it's hard. So let's kick it off. So here's how this will work. Again, we're going to have you decide in the race car theme if an EKG is a green light, yellow light, or red light. Okay. And along the way, we'll go over some pearls. And now that I've introduced myself, I just want to see, type in the chat for us, give us a little bit of an idea where you work, what setting you work in. Are you in the emergency room? Are you EMS? Are you primary care? Are you, oh, yes, Nicole. Awesome. Urgent care, Brittany. Nice. Okay. Wow, we have varied backgrounds so far. Nurse educator, yes, Matt, we love you. Rebecca in the hospital, what part? More urgent care. This is good for you urgent care folks. I've done urgent care. I forgot to mention that I've done urgent care and I feel like it's the hardest place to work. Family practice also hard. Okay, awesome. Yes, cardiology, Kimberly, NP for 25 years. New to cardiology. Okay. Yeah, you and I need to talk. New to EP, Stephanie says, currently outpatient and inpatient. Cardiology clinic. Eileen, hello. It's nice to see you. And RN, CV step down, acute cardiology. Okay, this is going to be pertinent for all of you, but especially for my urgent care people who have very limited resources. This is really good. I'm glad you're here because we're going to cover some high risk stuff. Jody's surgical and burn unit. I didn't know that. Okay. This is good to hear about you. I'm loving learning about you guys. All right. So let's do the EKGs, cardio inpatient and outpatient urology. Oh, that's it. That's a good mix, huh? Okay. So let's kick it off. Here we go. So why did we design this game? Well, first of all, Michelle loves games. And you guys have all met Michelle. She's my co-hostess with the mostest, always on all the calls with us. Teaches a lot of our classes in our 30-day EKG challenge. In fact, there's going to be one going on in a little bit. She'll have to jump off this call. But Michelle loves games, and she says, no one ever plays enough games with me. What we realized is when she does her games in the 3-day EKG challenge, people really love it. So we're going to kind of make this a game. And if you want to keep your own score, you can, to see how many you get right. Okay. And at the end, I'm going to tell you a little bit about a couple prizes that we're going to be giving away for participation. So looking for really, cheering on each other. I love that. And I'm looking for you to play, basically. So interaction is going to pay off. So I'm going to do a couple slides, just a few, of getting us all on the same page as far as speaking the same language, and a little bit on a normal EKG, just a little refresher. And then we're going to jump into our green light, yellow light, and red light EKGs, and hopefully you'll know where to put them. So just to define it, a green light EKG is one where you can wait. There's nothing really wrong. There's not going to be a lot of those, by the way. The yellow light EKGs are like, ooh, I should do something about this, but I don't need to stop, drop, and roll and do something right now. And then the red lights are, ooh, I need to do something like ASAP about what's happening on my EKG. Okay, so if you remember, if you've come to our 3-day EKG challenge, and I can see a lot of familiar names here, so I know you have, we talk about the terms for STEMI, because we're going to have some STEMIs tonight that we need to find, the contiguous and reciprocal. Okay, so contiguous means fed by the same artery. And for STEMI, we need to have at least 2 leads that are contiguous with ST elevation. Okay, and then we need to have basically 2 leads with reciprocal changes in the opposite mirror leads. So whatever's happening on, for example, the front of the heart, the opposite is happening on the back. And we're going to look at the 12 lead and figure that out. And we also need to be able to identify some ectopy. There will be some ectopy happening for us in the EKG, maybe one of them at least. We might have some artifact that we need to sort through. That's just too much noise. And we also need to understand that we're going to look for voltage. So the size of the R wave is going to matter in one of our EKGs at the very least. And we're going to see STEMI. So we need to be able to define that. And that is ST elevation MI. I do just want to pause really quick and just let you know that we've been living in a STEMI world for a long time. We hunt STEMI, we chase STEMI, we look for STEMI, no STEMI on our EKGs and urgent care ER, right? You always have that little stamp, STEMI or no STEMI. But we're changing into a landscape where we have a paradigm shift into looking for occlusion MI, OMI. And there's a lot of ways that, and I'll show you some of them tonight, there's a lot of ways that the heart tells us that it has blocked arteries other than just ST elevation. So it's picking up those subtle changes that what I'm going to test you on tonight that I really want to see if you know. Because at the end of the day, and again, I apologize if you've heard this before, but I'm on a soapbox right now. There was an article that came out in JACC, November 15th, 2022 now, that defined new STEMI equivalents. And I'm going to show you one of them at least tonight. So we are now being held to know those, the new STEMI equivalents. We need to know how to spot them, and we need to know how to get them to the cath lab, because it's not enough just to look for STEMI anymore. Okay, so again, one of our last basic slides before we jump into the good stuff, into the deep end of the pool, and we're going to look at a normal EKG. Now, a couple things that we're wanting to look for that we want to see. We want to see that there is no artifact, okay? So think to yourself, based on what you know so far, and type in the chat, yes or no. Can you trust what the EKG interpretation says up here? Can you trust this read? What say you? Can you trust the read? No, never. Good. Okay. Yes. Okay. I totally agree. Not always. Agreed. So this one is saying it's a normal EKG. And I saw somebody say already something. Somebody said that there was a negative. Oh, negative. You were saying no. Okay. So first things first, is there any artifact on this EKG? Is there any artifact? What do you guys think? All right. You're okay. Maybe a touch, like especially in AVL. Yeah, so it's not perfect, right? Is it enough to make you want to get another EKG? Because that's really the question. Yeah, everybody's not really like an AVL. Okay, yeah, but everybody says no, I'm good with this EKG. I agree. Because we can see what we need to see, right? So there's two things that I always want to see. I want to see if I can see a P wave, and I want to see if I can tell if there's a STEMI. And if I can tell both of those things, we're good, right? So everybody feels comfortable with that. Good. So the next thing I want to look for is I want to make sure that, I have, a P wave, right? Of course. So would you guys agree that this is a P wave here? And if you weren't sure, there's something you could do to sort it out. You could basically come here and you think where you think you see a P wave and go all the way up to the next one and look, there is a P wave there. And this one, it's not really looking like it's super obvious, but there is a P wave here. So yeah, everybody says they think there's P waves. Good. I agree. They're hard to see in some leads, but this is the take home. Just because you can't see them discreetly in every lead doesn't mean they aren't there. Always, this is a pro tip, always go to lead 2 first because it has the most beautiful Ps if they're going to be there, right? I want a P wave for VQRS. I want no ST elevation or depression. And I want, lastly, my T waves to be upright in all of the leads except for 2 of them. Okay, so all the leads except for 2. What 2 leads should have inverted? Another term we need to know, inverted T waves. So type in the chat, what leads should have inverted T waves? Good, Matt. Yes, AVR and V1. Good job, Kimberly and Eileen. And they are inverted, so we're happy. Now, the rest of them, though, they also need to be inverted or sorry, upright. So let's double check and see if they are. Okay, so this one is upright. This one is upright. This one's upright. Yes. That one is something sketchy is happening there. Upright, upright, upright. I think upright, not really sure, but this one is definitely, right? This one is, So KJ, what's up, KJ? So there is an inverted T wave here, and that's a problem because everything should be upright except for AVR and V1. What did this usually mean? It usually we're concerned for ischemia, okay? Inverted T waves can mean other things, but usually we're worried about ischemia. So this is not a normal EKG. Wrong, false. And also there is, if you look right here, this PR interval is short, okay? So it should be 120 to 200, and that's short. So this is just proof that if you did think before you could trust the machine, that you can't. This was not a normal EKG. Now, when you see a short PR interval, what should we worry about? You don't have one here, but what should we worry about? We should worry about a certain condition, and you'd worry about a Wolf-Parkinson's white. Eileen, good. Good job, good job. Or yeah, LGL. That's also possible. But we don't have either of those, so we're lucky. Okay. So now let's start with our fun. Yeah, go Eileen, I know. Oh, it's okay, KG. You just got here. Okay. So get your engine started. This is you in the car. Maybe that's let's see, that's KJ driving and that's Matt. And there's fire coming out because you guys are gonna kill it tonight. And we've got our checkered flag, we've got a green light. So let's get to it. All right, so let's do some green light ones, which are the easy ones. All right, so here we go. This is our first EKG. Do a gut check. What do you think? What do you think about this EKG? Is it normal? Is this a green light EKG where we have time to look at it some more? Do we have to stop, drop, and roll? Yeah, it looks pretty good, right? Are we pretty pleased? Yeah. Yeah, okay, good. Everybody's in agreement. So looks pretty good. Agreed. So finally, we have something we can say is fairly normal. And we say that because no artifact, PQRST, all the waves are the good size, the voltage is good, there's no artifact, there's no ST elevation, the T waves are behaving, we're good. Okay, so we have a green light EKG. Yeah? All right, good. So what about this one? Is this a green light EKG? And type in the chat what you think. Is this a green light EKG? Meaning, is there anything to worry about here? Okay, low voltage. Good, low voltage. Exactly. And there is artifact. Exactly. So Mary and Nicole, excellent. Okay, I totally agree. And Matt, there's artifact. So can we say if there's a P wave or not? Because right, we always want to know, is there a P wave? Is there a P? Yes. Okay, agreed. You can look over here in lead 2, you can see it. See it right here. That the fact that there's no asterisk here is also telling us the machine's seeing a P wave. So that's helpful. Can we see the ST segments well enough? We can. So I'm not too worried about this artifact. So you click it a new 12 lead. It's not wrong. It's definitely not a wrong call. But the question is, we have some low voltage and the machine is even picking that up. So is low voltage a green light where there's small R waves? Is that a green light or should we put it as a different color? Good question. What does the patient look like? Check lead placement. Excellent. I love these. So definitely a yellow light. I agree, KJ. Matt, yellow. Excellent. You guys are spot on. You need more info, right? So let's talk about low voltage for a second. Low voltage can happen. The worst case scenario is well, there's two bad scenarios. One would be a pericardial effusion. So fluid is in the way, right? And the signal can't get out through the fluid to the chest wall to be measured because something's in the way. So that would be something we wouldn't want to miss. And then you want to know if they have symptoms, right? Are they short of breath? Or they have chest pain? And then the other worrisome thing would be, do they have ACS? Now, there's other things that can cause low voltage that are not dangerous. For example, you can have a big chest or you can have large body habitus, and that's not anything dangerous. So that was good that you guys put this as a yellow light because we need to do more investigation. We need to ask the patient more questions and get a little more info. So what would be the test if you were concerned about an infusion that you would get? What test would we order? Echo. Excellent job. Everybody's fast on the typing. So good job. This is not a green light. You guys picked it up and we would do an echocardiogram. Excellent job. Okay. Let's do some yellow light cases. All right, so talk to me about what you see on the EKG. Tell me what findings you see. Now, first of all, while you guys are looking at it, I'm just going to go over and I'm going to look for my P wave. I definitely have one. I definitely think this is a sinus rhythm. The T wave doesn't look too far from the R waves. So that's good. There's no prolonged QT, even though I don't have my intervals. Aha, Kimberly says inverted T waves. Okay, agreed. Agreed, yeah, agreed. Inverted, inverted, inverted. Inverted, inverted. Okay, yes. So we're really worried about that. So how would we describe these T waves? Because there's nomenclature we need to use to distinguish this. Draw your lines. Yes, KJ. Also, yep, V5 and V6 have T waves that are inverted as well, but there's a further definition that really matters here as far as lingo. Possible elevation V2 and V3. Agreed. Agreed. Also, does anybody notice anything about the voltage? Does anybody notice anything about the voltage? And yes, Kimberly, they are contiguous, 2, 3, and F. The voltage is the R waves touch the next line up. Okay, so we have big voltage. And if we have big voltage, what can that indicate? And yes, you said exactly what I was looking for, KJ. Yes, it can indicate LVH. So here's the thing. I don't know yet if this is a red light or a green light, or sorry, a red light or a yellow light, because if we know the voltage is big and we know that that's usually indicative of LVH, could it be something more ominous or sinister like HOCM, hypertrophic obstructive cardiomyopathy? Could it be, just LVH from uncontrolled blood pressure? Well, that needs a little more ferreting out, right? But what we need to do is we need to consider echo, obviously, to really ferret that part out. But With LVH, you will have a T wave repolarization abnormality, and it will look like a reverse check mark. This does not look like a reverse check mark that is consistent with LVH. And that's why if you look back at what KJ said symmetric. That's the further qualifier. So whenever you talk about a T wave, you always need to say if it's inverted, if it's symmetric or not. Because if it wasn't symmetric, we could pretty much put this as straight up yellow light and get an echo. Hi, baby. Remy's here to help us with class. So these are inverted and symmetric. We did see a little bit of ST elevation in V2 and V3. And so we're concerned more about ischemia than anything else, right? So we're leaning towards this is probably a little more towards the red light. Okay, so good job, guys. Good job, good job. All right, let's do a case. No real faces, of course, of any patients. These are just made up pictures, but they're fun. So this is a 63-year-old male, and he has chest pain. And he was shoveling some snow, and he describes it as a tightness. It goes to his jaw. It's an 8 on a 10, and it's been going on for about an hour. Yes, it's exertional. KJ, strong pickup. So I want to touch on that for a second. Thank you for bringing that up. So whenever I'm working with a cardiologist and I have a patient I think needs a cath, if I say exertional pain, that's the way to get my interventionalist interested, because that's almost always ischemia. Okay, so this also has more of a, like KJ said, also classic signs, right? They're not always so typical like this. But yeah, we're pretty concerned because he also has a history of hyperlipidemia and hypertension. He's probably also diabetic because it just all seems to go together. And he probably also has some chronic kidney disease that he's going to get diagnosed with. And yes, it does kill a lot of people. Exactly, Robert. So then if you go over here, here's his EKG, the first one we have. And in that article that they put out that I was just talking about, and by the way, that article is open source. Anybody can get it. It's called The Chest Pain Guidelines for the Emergency Room, New Consensus Update. And they said now there's really an emphasis on getting serial EKGs. So can we do that in an urgent care setting? It's honestly probably pretty hard, right? Because urgent care, you're always swamped. You don't have rooms. You maybe have one tied up with a procedure. But I will tell you that, yes, draw your lines exactly. We're going to do that in a second. But I will tell you that in the case like this, it would be worth it, because this printout is saying it's a normal EKG, but my friends, it is not normal. Okay. And it's heading towards a bundle. Yes, there is a bundle forming. You are very correct on that, but it's not yet formed. How do we know that? Because the QRS is not over 150, or sorry, 120 yet. So looking at this, one thing that I just want to point out to you is this is not normal, right? AVL should not be inverted, and V1 should not be upright. So there's already two things. And then KJ said, which is very good advice, KJ. So thank you. KJ always knows, draw your lines. And there is a little bit of ST elevation happening in V2 and V3. Now, why does the machine not call STEMI? Does anybody have any thoughts? Exactly, Robert. Why is the machine not calling this a STEMI? This patient is 60, he's male. We know in V2 and V3, the criteria is they must have 2 millimeters of ST elevation to be considered a STEMI. And we don't need any reciprocal changes here because we're not looking at the back of the heart. So why is it not calling it a STEMI? Okay, I stumped you guys, right? Because it does not know the new rules. It's actually not yet STEMI criteria, and it doesn't know the new rules. You're right, KJ. But here's the, because it's not yet 2 millimeters. Are we potentially heading that way? Yeah. So this is 10:39 in the morning. So we're going to get the next EKG. We're going to get a serial EKG. And just 4 minutes later, 4 minutes later, we are now meeting STEMI criteria. You can see we now got our 2 millimeters we needed in V2 and V3. And you can see that this is changing as well in morphology, which means shape. And so now, what artery do we think is the culprit lesion? Uh-oh, I know, right? STEMI developed in 4 minutes. Can you believe that? This is a real case, okay? So, what do you guys think? Okay, exactly. The left anterior descending. Okay, so we have to be fast typers to beat KJ and Matt. They're very, very fast. So Nicole, I agree. This is an LAD occlusion, and we know that because the leads are all contiguous, right? V1 through V4. And so unfortunately, oh yeah, good job, Nicole and Robert. This is not the end of the story because we're not at the hospital yet. This was an EMS call. And this was the last actual EKG. So you can see the STEMI progressing, and they then develop a full right bundle branch block in V1. And the thing about the take home on bundles, and this is as pro tip number 2 for the night, is that bundles can develop in an LAD occlusion left or right. Okay, so left or right. All right, good job, everybody. So that patient would go to the cath lab immediately upon arriving to the hospital. Okay, so what about this one? Is this yellow, green, or red? Oh yeah, good advice. What does your gut say? Exactly. Always trust your gut. I do teach that, Robert. So tell me what you guys think. Is this green light, yellow light, or red light? Patient has a little bit of palpitations. He's vitally stable and he just feels his heart fluttering a little bit. He's 45. What do you guys think? Anybody want to take a stab? Okay, potentially red, right? Potentially, as in we need to do something. We're not going to just refer this patient, right? So yeah, okay, everybody's saying red. So what is going on here? Is the machine right? Is this an SVT? Need more information. Okay. There, Nicole, I love that you want to look for JVD. Yes, we do want to do that. No JVD on this patient. So, and the leads are placed correctly. So if we have to like decide what this is, can't see well, but SVT, does he have a pulse? He does have a pulse. Okay, everybody's thinking red. Everybody's voting red. I like it. Okay, good. So, what is this rhythm? What do you guys think? Okay, I like that you said AFib. So if you think it's AFib, and I know why you're thinking that, because if you have an asterisk right here, a lot of times it is AFib because it's not seeing a P wave. But what you would do in that case is get your calipers and you'd measure it out. And what you would see is it's nice and regular. And when there's no variability to the R to R interval, another fun term, then it's not AFib. And when AFib gets fast, though, it can look a lot like SVT. So it is really hard to ferret out. But this is none other, as Matt said, SVT. And yeah, I agree, KJ. You committed, right? And you made a decision, and that's what we're here for. We're here to practice. So anyway, looking at this, we got a guy who's a heart rate of 144. Now, is it possible, let me just throw this out there, is it possible that he potentially could be sinus tach? Is that a possibility? What do you guys think? Yes or no? Is it possible that this could be sinus tach? Because technically, right, up to 150, 160. Nicole, good. Is he in pain? He's not, but good question. And it is possible. Everybody agrees it is, right? So that's where the history comes in. So we would ask him, like, are you in pain? Are you anxious? Do you have any volume loss? Are you anemic? Have you had your thyroid? So checked recently your Z and thyroid storm. No, 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 no. Just nothing. And then his heart sped up and stayed consistent and regular. So that's none other than PSVT. And then it resolved. But it didn't resolve until we treated him. So what should we do? That's the big question. If we think this is a red light, um, could we try anything while we think about it? He actually did get adenosine. Yes, he did. But could we try anything while we're thinking about it? Has it happened before? Good. Valsalva, exactly. Vagal, if he's stable, good. If true SVT, vagal maneuvers, it's not going to hurt him, right? To try and see if it breaks it. Has anybody heard of the modified Valsalva? Maybe the urgent care folks have, where you actually lay the patient down, they blow on something, a syringe, closed syringe, and you lay them down and raise their legs up really fast. Has anyone heard of that? You can look it up on the video on YouTube, but basically it's a really effective way to break the SVT. Good. Yeah, lots of videos on social media, but it's really taken off. It's really a sizzling way to treat it. So you could try that. You could, wherever you are, you could do that. Um, even if you're in a clinic, right? Whatever. Anyway, he did get a adenosine, it did break, and he eventually got an SVT ablation. But a lot of times people are tempted, oh, I'll just put him on a beta blocker and see him in a couple days. No, this is our red light. So you guys did good. Awesome job. Teamwork. Teamwork makes the dream work. Right. Exactly. All right. So here we go. I'm going to tell you about this case, and I want you guys to tell me, or a forceful cough. Yes. Yes. I like that, Marjorie. Okay. So Matt says nasty. I'm going to tell you about this, and I want you to tell me green light, yellow light, red light. Okay. He comes to the COVID tent during the height of COVID wanting a COVID test because he's got a cough. Cough is dry. He has no fever, no chills. He has no lower extremity edema, no JVD. And he's vitally, when they give you the pulse, they give you the pulse off the pulse ox and it's reading 30. Is that heart rate correct from the pulse ox? It's not, right? It's absolutely not right. Oh no, oh my gosh, no, exactly. Yes, these are PVCs, exactly. These, and there is a run of technically a VTAC. So this, good job, Marjorie. Yes, looks like my daily telemetry runs of NSVT. So I agree. This is a red light. He was already on metoprolol. He had had a history of palpitations. And yes, it does, if you have PVCs or AFib, you cannot get an accurate pulse ox heart rate. And so if you're in wherever you're working, especially in urgent care, if you have vitals that are weird, question them. Like a heart rate of 30. No, it's not picking it up. So just redo your own vitals. It's just the safer way to go. So what do we do with this patient? He's at the ER. And he's basically, what do we do with him? Yeah, get in the habit of actually feeling the pulse. Exactly, Mary. So what do we do with this? What should we maybe up his beta blocker and have him follow up with his primary or cardiologist, or should we start him on an antiarrhythmic drug? Or should we do some labs and a chest x-ray and maybe admit him? Okay, so what labs would you check, Eileen? And I love that you said that. What labs would you check? Because now we've committed him. He's going to stay. Okay, we want to get a mag. Love that, Matt. He's going to be monitored, and we would only put a Holter if we're sending him home. But I don't know if we want to send him home. Potassium, absolutely. These are great. Does he have any chest pain? Does he drink coffee? Would we consider Lido? Okay, these are all good. Does anybody want to get a TSH or a troponin? No, it's okay. It's all right. Yeah. Okay, good. Teresa wants to get a troponin. And yes, good. Nicole, drug test. I like this. I like this. So need more info. I need to see labs. Symptomatic chest pain will determine course of treatment. Yes, Mary and Nicole. Love it. Okay. So this patient did get admitted. All of his labs were fine. His troponin was not elevated. But he did get admitted because they needed to find out why he had so many PVCs. They admitted him so he could get an echo. When you have a lot of PVCs, you can drop down and you can get a depressed ejection fraction. And anything over 10%, you're worrying about that. Also runs a VTAC. So he ended up getting a cardiac MRI because in addition to echo, cardiac MRI, ruling out things like ARVD, ruling out, fibrosis, amyloidosis, all the things. None of those were going on. So he went in and he got an EP study. Yes, they don't perfuse exactly. He got an EP study and they ended up doing an ablation, a PVC ablation, and he was asymptomatic after that. So it was a happy ending, but only 46. So that was someone where we would normally be like, oh, you're fine. So if you felt this, you might feel some irregularity and you might think it's AFib. So anytime you feel irregularity, just get the EKG. Speaking of irregularity, what about this one? What about this one? What do you guys think? Red light, yellow light, green light? Okay, yes. This is AFib. If anybody else says A flutter, you'd not be wrong. Patient was going in and out of both. Okay. Yes. So when you have an irregularly irregular rhythm, and we're looking at V1, okay, V1's our best one here. And let's just talk about this for a second. So these two down here are pulled out for us for rhythm strips, but we don't need them. In fact, I would just fold over the EKG because, they're confusing on the eye. I want this because I want my rhythm strip to tell me what my rhythm is. And then I want my 12 lead. Okay. So looking at this, in addition to AFib, what else is, and it is irregular Marjorie. Yep. Yeah. And some people do think that this is consistent with like an organized flutterish type pattern. So what else, if anything, do you see wrong other than AFib? What about over here? How would we describe these T's? Inverted T's, yes. And how else would you further quantify them? They are symmetric. Good. So we are very worried about this patient, right? Because symmetric inverted T's, there's a lot of bad things that happen with symmetric inverted T's. It's okay, no worries. So the other thing is, does anybody notice what's happening in V2? How to describe that? How do you describe what's happening in V2? Right? There's something happening in V2. That T wave shouldn't be going two directions at once. Does anybody know the terminology for that? It is actually called biphasic. Good. Yes, Matt and KJ to the rescue when we don't know the answer. Thank you guys for being there. Yes, biphasic, when a T wave goes up and down, that's bad. And inverted, if the combination of those are Welland's warning. Welland's warning, if you don't know how to spot it and don't know what it is and don't know what it means, you should know, study up on that, because Wellens is now on that hit list in that article. It's someone that needs urgent revascularization within a week, or they have a high risk of dying from an occluded LAD. Okay. So these T waves, now you're starting to see, hopefully, that this is these symmetric inverteds, they're no good, right? And biphasic, even worse. But in addition to the AFib, there's lots going on here. So I would say this is, for me, it's a red light EKG. Yeah, good. It's okay. I do know what you mean. KJ, I know. Okay. So anyway, red light EKG needs more urgent therapy and treatment and workup. Let's do another case. Here we go with a no roll patient's face. And if I were to look at him, he's probably not 78, right? But he says some things that are concerning. I have tightness. It goes to my shoulders. It's when I work out. So exactly, KJ's already all over it. KJ's like exertion. And it's a 5 out of 10, and it started 3 days ago. The patient has a history of previous stent, which is concerning. So the history, right? So what could you ask him in regard to him having a previous stent and pain like this to help you make your decisions? What could you ask him? Does this pain feel the same? Exactly. Is this similar? Very good. Is it relieved by rest? Yes. Was it similar to the pain last time? Exactly. That's the money right there. Because if it is, then that's kind of like there's a couple things that get my attention, and that is definitely one of them, right? That, and I feel like I'm going to die when they're pale, cool, and diaphoretic, that gets my attention too. So here's his EKG. What what do we make of this? So I know what KJ is going to say, so I'm just going to do it. I know Mary is rocking it. We're glad that Mary came tonight. Okay, so KJ is going to say, draw your lines. I already know, so I'm going to start doing it for you guys so you guys can see the lines. What does KJ mean when KJ says draw the lines? We're looking for depression and elevation. And without the lines, Mary can already see there is some significant depression in V4, V5, V6. So I love that you saw that. There is elevation. Yes, there is suspicion for MI. Okay, I agree. This is where the money is, right here. Here's your elevation, and you have a pattern of widespread depression. Now, what we don't What we don't have is we don't have our 2 up. We only have 1 up, and we have a lot of down. We do need to give AVR respect, exactly. But how would you document this? You would say, I'll just to give you the example, you would say there's widespread depression because it's not in contiguous leads. It's contiguous in V5 and V6, 1 in ABL, yes. But then there's also lead 2 and V4, which are not contiguous, right? So it's a widespread, and Mary says a left main lesion. Mary, you're in my brain. Not in sister leads, exactly, KJ. So when you have the widespread depression plus elevation of at least 1 millimeter in AVR, it's another one of those things on the bottom of that list in the article where they say, get the patient to the cath lab urgently. This is to be treated urgently because a lot of times it is a left main, which is very, very bad to block. It's the most proximal artery that feeds the system. But also, this is going to be read as non-specific ST wave changes. That's all it's going to say. It's not going to say, take me to the cath lab. So these are things that honestly, it's a high risk finding. We've already shown you a couple high risk things tonight, right? From that article. So hopefully now your eye will start to spot this. And this is definitely a red light EKG. You do not want to see this in urgent care and refer to cardiology because they will die. There was a case that was similar to this, not exact presentation of the EKG, but similar findings, that they had syncope multiple times, was in their 80s, and they ended up getting scheduled for an outpatient stress test, and they ended up coding that night. It's something you don't want to mess around with. So this is a hot potato. This is definitely a red light. Here's another patient. Let's just no real faces, of course. 18-year-old male who had syncope, just standing there, and he passed out. His uncle died at age 30. So what do you guys think? How worried are you on a 1 to 10 scale? Oh, yeah, I love that you're thinking hokum. KJ's like 10. Matt says, uh-oh. Mel, okay, everybody's thinking hokum. I love that. I love that. Mary's very worried. These are all good. There's one other thing you got to think about. Squat down, and yes, you can squat down, see if the murmur changes. That would tell us about hokum. There's one other thing. Big bad wolf, zebra, yes. Brugada. Okay, so let's look at the EKG together. What do you guys think? Is this hokum? Or is this Brugada? And good job, Nicole, for coming up with that. And Eileen went out on a limb. I love it, Eileen, for your bravery. Eileen, yes, this is Brugada. And Matt says Brugada with 2 exclamation points. But why is we saying that? And KJ, yes. So here's the thing. Brugada is a high risk finding you can't miss. It's very rare. And I just had one today, actually. I was very excited. Yep. And V1 and V2, you have ski slope ST elevation, ST elevation in V1 and V2 with no reciprocal changes. Okay. So this is ski slopes. Yes. Good, Eileen. And that's how you spotted it. So that's what you got to do with these things is it's pattern recognition. And when you see the pattern, it's like a face. And yes, I totally agree. Good job, Eileen. Okay, let's do a couple harder ones, maybe ones that are most likely red lights. So what about this one? This one's easy, right? You guys are like, oh, I already know. I already know. I love how Mary's congratulating Eileen. I love that. Inferior STEMI. Wow. Yes, you guys. Look at that. This is easy, right? You draw your lines. KJ, I'm surprised you didn't already tell me to draw my lines. You need 1 millimeter here to be significant for STEMI. We have 2 up. Let's go find our 2 down. Yep, over here and over here and actually over here. So we do meet criteria. This is absolutely a red light. It's going to go to the hospital and it is an inferior MI. For bonus points, what artery is most likely occluded? For bonus points, what artery is most likely occluded? What do you guys think? Any thoughts? Because these are your inferior leads. Oh, nice. You guys are all over it. You're so smart. Okay, good. All right. Now, I did throw this one in just because I wanted to share with you how subtle it can be sometimes. Okay. So it's not always that obvious, but if you look here, this is why KJ always says, if you'll come on these classes with us, you'll see KJ will always remind us to look for our lines because you just need 1 millimeter. You have it in 2 contiguous leads, and you do have depression you have it in ABL, and you have enough in one, which are reciprocal. So this also is a STEMI, but it's very subtle. So you really have to look closely. Now, speaking of look closely, another patient, not a real patient space, comes in, has pain in the shoulders that radiates to the front. Just get in the habit. I know, KJ, if we could just get in the habit, you wouldn't have to remind us every time, right? So he has pain in his shoulders. It radiates into his chest, but it got better with Motrin. So he says, I'm here for an EKG. I want to make sure I'm okay. My pain's almost gone, but I'm getting ready to go on a trip. So I'm going to put this EKG up for you. Okay. And I want you guys to take a look at this. I want you guys to take a look, and I want you to decide, is it red light, yellow light, green light? And what are you going to do? I'm going to grab something. While you guys are looking, I'm gonna grab my heart. Okay, so Nicole says, oh boy, no red, no trip for you, sir. I totally agree. I love this. Matt says pericarditis. Okay, so everybody's agreeing this is red. I wanted to show you on the heart real quick. So the concept of reciprocal changes, right? So let's just say on this EKG, can we agree we have inferior wall elevation? There's significant elevation that meets STEMI criteria 2, 3, and F, right? So that would be the inferior one. Where we would normally look would be the opposite part of the heart for reciprocal changes. We've been looking in 1 and ABL, right? But we don't have those here. So because we don't have them, there's no depression. This is not a STEMI. This is not a STEMI. What a big heart you have. I know, right? That thing travels all over the country. So Matt and KJ already said pericarditis. Do you guys agree? Does everybody agree with Matt and KJ? What do you guys, so chime in, everybody else. Where's Nicole? Where's Mary? Talk to me. What do you guys think? Do we agree? Okay. Jody, yeah, good. I love it. Okay. So this is elevation, yes, but there's no depression. So not a STEMI, this is a STEMI mimic. This patient did go to the cath lab despite having no depression, and they did have clean arteries. If there's a doubt, they will take them to cath lab. However, I'm going to show you why there's 2 signs here that also supported the pericarditis. And one of them is actually right here, the knuckle sign. If you can put a knuckle underneath the PR segment of AVR, and there's also the PR depression in lead 2. Those 2 things combined are really significant. Okay, so again, this is not a STEMI, and it got better with Motrin. What might you hear when you're listening? What might you hear on this patient when you do your cardiac exam? You might hear a rub, exactly. Pericardial rub, exactly. Good. Does a rub have to be there for it to be pericarditis? Does a rub have to be there? I know, good job, Mary. No, exactly. Good. Boy, I can't fool you guys. You guys are all over it. Okay, let's do another one. This is a 65-year-old male, and he, lead 2 is leading me back to AV block. Okay, let's go back, because if there's a question, let's go look at it. So what's actually happening, Nicole, let's go down to our long lead. If you go over here, this is our rhythm strip. And there is something going on, actually. So the big question would be, do we have a P wave? Do we see a P wave? We do. There is one right here, but there's not one right here, right? P wave, P wave, P wave, P wave, not one right here. P wave, P wave, P wave. Okay. So what those extra beats are is they're actually ectopy, and he was having ectopy because of the pericarditis. And so whenever what you're saying about the delay is happens after you have ectopy. It's called a compensatory pause. The heart kind of resets. And so this is just probably a PAC. It could be a PJC, but it is ectopy. And Right here, yes, it's in a bigeminal fashion, but it's not consistently so. But definitely good that you caught something was going on. And whenever you're not sure, it's always good to take a better look. And I totally agree, KJ. Totally agree. Okay, let's do this guy. He's 65 with chest pain for 3 days. He had a positive nuclear stress test, but he didn't want to do anything about it. But now he's eating 5-nitro and he's not feeling better. So he's here in the clinic and he says, I really think we need to do something. Okay. So without even seeing the EKG, is he a red light, green light, yellow light patient? What do you think? This is easy, right? This is easy. Everybody will get this one. Yeah. Yeah. And I like red with lots of D's. Okay. Yeah. Totally agree. Eating 5-nitro, you're going to the hospital. I mean, it could be GERD, right? The nitro is not working. It could be expired nitro, but no, you had a positive stress test. So here's the EKG. So the question is he a STEMI? That's a very good question. Is the nitro good? You're not supposed to do over 3. I know. He wasn't following the rules. Red, how not syncopal? How is he not syncopal? Yeah. Okay. All right. Is he a STEMI though? What do you guys think? Is he a STEMI? And we're almost done, so feel free to guess. We're on the home stretch here. It's not a STEMI. It's not. You're right, KJ. But why? Because we don't see enough ST elevation, but there is some, right? If any of you are like kind of scrutinizing this and like, I see something, then let's take a look. So if you go over here, there is some ST elevation, but it's not yet significant enough. Okay. Does anybody else see anything? Okay. Matt says biphasic and V4. Mary says, I see some abnormal T's. Love that. I agree, Mary. Inverted, symmetric. And also over here, biphasic. Okay, good job, Matt. And symmetric. Oh, I love it. These are inverted, symmetric, and V5 and V6. Okay. Now, what's going on in an AVL? How would you describe this? How would you describe this? I mean, it's low voltage, exactly. Low voltage can also happen with ischemia. Good job, Nicole. Yeah, you know that, right? So this gentleman, let me ask you this. He did go to the emergency room 5 minutes after this EKG was taken in the emergency room. He was code STEMI. When they went in, they found lesions in what arteries? What 2 arteries did he have lesions in? Flow limiting lesions. Anybody want to guess? Okay, circumflex. Yes, yes. Yeah, and the LED. So good job. Yes, perfect. Eileen, nice. KJ, of course, and Matt, yes. So, there's another clue on here too, and that there's hyperacute T waves, and those are also something that are on that article. So there's a lot of clues here that this patient had a sick heart, but all it says is ST2 of abnormality. Consider lateral ischemia. So there's, as you can see, hopefully now, like as you're starting to put this together, you're like, oh, it's not just about STEMI. It's not just about STEMI. It's about more than that. And the LAD has a lot of different ways. That's the other take home. The LAD has a lot of different ways to complain that it's blocked. So the recap of tonight, subtle changes can have big meaning. Learning EKGs takes practice, and we can't rely on the machine. We need to rely on ourselves because we have a 0% miss rate. Okay. So I wanted to tell you guys that as I've been watching your interaction in here in the chat, that I have a prize. And I have a prize, and the prize is actually going to go to Mary Wanjiku, and you are the winner of a STEMI equivalent badge. This is made by Scope Education. It's very cool. Just make sure to give me your address in Facebook Messenger if possible, so I can mail this out to you. But I told you guys if you were supporting each other on an interactive that I was going to reward you. So yay. Thank you for playing with us. We really, really had fun. So in case you are interested in learning more, so if you want to order more, you can talk to Matt. He's got a link. I don't know what he charges for them, but they are so amazing. So just, I'm sure he'll hook you up, KJ. But in case you want to learn more in a style like this, we're starting a program again in May, on May 1st, that's called EKG Launchpad. And we're doing a special edition this time only, where we're going to be actually including an EKG workbook and a badge with the whole program. And May 1st, we start classes where you'll come every Wednesday at 4 p.m. PST, and it'll be more interactive. So we'll have you come off mute, you'll talk to us, and we're going to start from the basics and move on up. So it's more for the basic learner, but it's a really interactive environment. And you get two ways to play. You get four Zoom calls with us in May. I'll give you the dates. And then you also get a learning portal, and you get lifetime access to the learning portal. So we'll store your recordings there of the live calls. And you also get sessions in the Facebook group that you can watch, that we have over 2 years of pre-recorded stuff in there that we've done over, I think it's the past 3 years. And there's a whole library of things you can go back and look at. So it starts again May 1st, where we're going to do EKG terminology and fundamentals. We then move on to basic 12-lead intro and arrhythmia intro, and we'll be using that workbook in our class. We'll be playing the strips live, and you'll have it in front of you because this will come with your course. We'll do some basic arrhythmia practice on week 3, and then week 4, which is the 29th, we're going to have kind of a session like this where we put it all together. If you join before Wednesday, you'll actually get to go to that call as well, because we're doing the last call of the cohort right now for April on Wednesday, so you'll have an extra bonus session. So you get 5 hours of Category 1 CME when you join us. And this is just one testimonial from one of our students who's in now. She's really been enjoying the course, but it's a great resource for anybody who's at a basic level and you want to build your skills. This session tonight was designed to help you basically see where your weaknesses are, if you had any, and know where to shore up. And now, however you do this is up to you, whether it's practicing on your own, coming with us, right? But getting the practice in, because we owe it to our patients not to miss anything. Okay, yes, great teamwork. I'm loving all these comments. Yes, I know. I'm loving seeing the new people on here with us. But this is where the link where you can go to grab your spot in the launch pad. It's only $97. And again, we'll mail that workbook out to you once you order, and you'll get instant access to the recorded classes. And then you'll get to come to the lives. We do record them. So if you can't make it live, and then you do have also one other thing I forgot to mention, we're doing a bonus class on Sunday in this group, the Launchpad group, called High Risk EKG Findings, where we're going to do more practice on the high risk stuff. And I'm going to bring out that article, and I'm going to really go like deeply into like more of the findings. So that's a bonus as well. So if you joined before then, you'd get access to coming to that live as well. I think it's at 3 o'clock Pacific Standard on Sunday. So it's a good opportunity to join. And again, great value. So if you have any questions, let me know. Otherwise, this is the link, and I'll be posting it in our group for you guys to join us, but we'd love to see you. So thanks for coming. And it's been so fun. I've loved getting to know you guys. And thank you again, Matt and KJ, for always being so amazing. This was fun. And then we'll see you guys hopefully in the launch pad. Hey, Alice, how are you? All right. See you guys later.